Now I'd like to call upon our next speaker, Dr.Mounica, who's a pediatric endocrinologist. I request ma'am to talk on bone health in SMA.
Thank you, Dr. Ramya. Thank you, Dr. Alham and organizing committee and all the families for giving me this opportunity to talk on bone health in SMA. So this is my outline today. So I'm going to talk briefly on why bones are at risk of fractures in SMA, what can be done for a good bone health, and what is the importance of doing serial DEXA scans, and when and why is alternate used. So, as it has been mentioned in Dr. Ramya's lecture, like different organ systems which are involved. So, SMA commonly causes people to have bone and muscle problems, and these can frequently involve the spine, hip, joints, and bones. And anyone with SMA is at a risk of thinning of the bones, osteopenia, and recurrent fractures. So, why the bones are at risk? Now, here we need to understand that bones in children are different from bones in adults because growing is a continuous process. So, the bones in children are continuously undergoing a remodeling process. Okay? So, what keeps these bones at risk? So, first factor being a poor nutrition because of the various challenges in feeding. Second, limited weight bearing activity. So if there is a limited weight bearing activity in the non-ambulant children, so there can be a risk of poor bone accruals. Bone accrual is, in simpler terms, is bone assimilation. So if there is poor bone accrual, there is reduced bone mineral density. Low muscle mass can lead to lower mechanical loading forces on the osteocytes. Osteocytes are nothing but the bone forming cells. And also, in some of the mouse models, it has been found that there is a direct interaction of this SMN protein with modulators of the osteoclast activity. So, just to brief up, like osteoblasts are the bone forming cells, osteoclasts are the bone eating cells. So, there has to be a balance between these two kinds of cells for the bone remodeling to happen. So, what does this SMN do here? It modulates the activity of the osteoblast, which alters the bone remodeling and also it affects the bone mineralization. And ultimately, what is the risk of having a low bone mineral density? Is it predisposes children and adolescents to increased risk of fractures. So, what can be done? What measures can be taken for maintaining a good bone health? So, at our center, we keep a check. We annually monitor the blood vitamin D levels, bone profile, which includes blood calcium, phosphorus, alkaline phosphatase, parathormone, and annual DEXA scan for measuring the bone mineral density. So coming one by one, so vitamin D supplementation. So at our center, we keep the infants at regular vitamin D prophylaxis. So infants less than 6 months receive about 400 IU daily, more than 6 months to 6 years about 600 IU, and children who are more than 6 years, we keep them on 1000 international units daily. So and annual vitamin D level checks are done. So this is the table wherein if the vitamin D levels are more than 20 it is sufficient, less than 12 is called vitamin D deficiency, and anywhere between 12 to 20 is vitamin D insufficiency. And if we find that the children are deficient or insufficient, then these are the treatment doses for the children. So the vitamin D deficiency has to be treated for at least 90 days, following which they have to be kept on maintenance daily doses of vitamin D. And when we are supplementing, we have to ensure a daily calcium intake of at least 500 milligrams. Coming to the next point, that is calcium intake. So calcium is very important again. So we have to ensure, like our dietitians, I'm sure will be talking more on calcium-rich foods and all. So dietary intake for 0 to 6 months, we have to ensure at least 200 milligrams daily. Between 6 to 12 months to 60, and the child who is more than 12 months of age, so minimum we have to ensure 500 milligrams of dietary calcium intake. And if the dietary intake is not going to be sufficient, then we keep them on regular calcium supplementation. Exercises. So bone mobility is very important for the bone mass assimilation, for which the exercises are very important. So the children have to be regularly on their physiotherapy and occupational therapies. So we have to make the children as mobile or the non-ambulant children. The movement of the body limbs is important to prevent the local loss of the bone. So coming to DEXA. So DEXA is dual energy X-ray absorptiometry. So this is how the DEXA machine or the arm looks like. So it is done to look at the bone mineral density. So what is the aim of DEXA? Like what are we achieving at maintaining the bone mineral density in the normal range? So basically it's most important to prevent the fractures, because in children who are just like trying to be ambulant, even one fracture can put them at a risk of like having further bone health loss. So we have to prevent the fractures both in ambulant and non-ambulant children. So in the ambulant it means protecting ambulation for a bit longer. In the non-ambulant children, there is a risk of having spinal morbidity in terms of spinal fractures and having these spinal deformities. So this is our aim, that we prevent the fractures in these children. So this is an example. So we do serial DEXA scans for our children with SMAs. So what do we do? So as you can see in this report, the DEXA, here the spine has been taken for the DEXA scan, and this is reported in pediatric age group in Z scores. In adults it is reported in T scores. So the Z scores, you can see here it is reported as minus 1.0. So if the Z score is less than minus 2, it means it's a significant, it is osteopenia in children. Okay, so this is one example of a child who came to us in 2020, whose Z score was then back then at minus 1. Then in the next year, when the exam was repeated, so the Z score came at minus 1.4. And in the successive year, again the Z score was at minus 2.9. So here, like when the Z scores are dropping and there is osteopenia here, so Z score of less than minus 2, it is important to prevent any fractures, and wherein the role of the bisphosphonate infusion comes in. So serial DEXA scans help us to decide like which children need bisphosphonate help. So how do bisphosphonates strengthen the bone? So here, as you can see from the picture, so this is a osteoclast, which is a bone eating cell in simpler terms. This is an osteoblast, which is a bone forming cell. So there needs to be a good balance between the bone forming and the bone eating up cell, right? So what do these bisphosphonates do is, they inhibit the function of the bone eating cells. So thereby which the osteoblasts undergo apoptosis. Apoptosis is basically the bone forming cells like undergo cell death, and then it prevents the constant eating up process of the bone. So that is how this bisphosphonates strengthen up the bone. So zoledronate is the third generation bisphosphonate which is preferred for children. So how this is the dose what we give for children, 0.1 milligram per kg per in a year, which is divided into 2 divided doses, which means we give this alternate infusions at 6 monthly intervals. So indication, like if the child, as per the position statement, it is said like if the child has even one vertebral fracture, irrespective of the bone mineral density, or 2 or more long bone fractures by 10 years, or 3 or more long bone fractures by 19 years, and a BMD score of less than minus 2 ST, so it is indicated to give the bisphosphonate therapy. Coming to the commoner side effects. So acute phase response. So it's like a flu-like illness. So if especially this is seen with the first dose of the illness, the first dose of the zoledronate injection. So usually the children may run with fever up to 24 to 48 hours. They may present with vomiting, bone pains, but it resolves in 24 to 48 hours. And the other side effect which we have to be aware of is hypocalcemia and hypophosphatemia, and hence the importance of maintaining or like having a good calcium and vitamin D level before giving the zoledronate infusions. And some of these in smaller font are the rarer side effects like iritis, atypical fractures, esophagitis, which have been reported in literature. So these are the most commonest: the fever, hypocalcemia, and hypophosphatemia. So, yeah. So, with this, I would like to end my talk, wishing all the children here at SMX a good health and good work.
Thank you so much, ma'am, for that talk. I would like to request one of our mothers of one of our SMA kids, Mrs. Manopriya, to please come up and hand over a memento to Dr. Mounica.